Right, so my name is Evie, and I'm a new consultant at the Royal. So today I am going to present um, some important things about the CAR T cell therapy, so chimeric antigen receptor T cell therapy, the good things, the bad things, and what to expect. Now, the only reason that I chose this topic is because the hematology team at the Royal, is commissioned and has, like all the approvals to start with CAR therapy over the next weeks and months. So hopefully at the end of this presentation, we will all know a little bit more about T-cell therapy. What is it? The indication, how effective this is, what are the complications, short-term and long-term, from CAR T-cell therapy and their management. We're going to speak a little bit more about CAR T specific toxicities, such as the immune effector cell associated toxicity, the cytokine release syndrome, the immune effector cell associated neurotoxicity, the immune effector cell associated HLH-like syndrome. I know they're really, really long words, that's for sure. And of course, about the infections in these patients. We're going to close this presentation and we're going to talk a little bit about the implications of having patients undergoing CAR T therapy for ICU. We're going to have an overview of the utilizations of resources and I'm going just to present quickly some 4-year outcomes from a UK multicenter observational study. Let's start then. So chimeric antigen receptor therapy, or the CART, is a type of immunotherapy which uses modified T lymphocytes to kill cells expressing a target antigen. So as you can see in the image on the right side, we have with blue the T cell, and then we have here a chimeric antigen receptor. We have an extracellular portion, which is exactly the portion which acts as an antibody, and it recognizes the cancer antigen. We have a spacer, and then we have an intracellular bit. So this intracellular component has been developed through the years. So on the first generation CAR cells, we have the domain, just one domain, which was the activated signaling domain for the T cell. But this didn't show enough activity. So then they added some extra co-stimulatory domains that they make the T cell to become more efficiently activated. And depending on the type of this co-stimulatory domain, you can have, for example, more activation, but this means that you're also going to have more toxic effects. Okay? So just an overview of the CAR cell therapy and how it goes. We can see from the top, we have the patients. They undergo apheresis of their T cells, and then there's T cells, they go to the lab. In the meantime, the patient undergoes some, I would just say, weak, not really strong chemotherapy because the cancer is still there. So the CAR T cells, they're made in the lab with viruses which insert the gene for the CAR to the T cell. Then the T cells, they express this chimeric antigen receptor. They are expanded again in the lab with certain culture media, and then these are infused back to the patient. And hopefully they will recognize the cancer cells and kill them. So clinically, patients will just be, they will come 5-6 days before they get the infusion of the CAR T cells to the ambulatory care. On day 0, they're going to have the infusion of the CAR T cells, and they're expected to stay for at least 10 days. The indications for CAR T cell therapy in the UK are for diffuse large beta cell lymphoma, mantle cell lymphoma, beta cell acute lymphoblastic leukemia in adults and children, but there are many clinical trials running and seek to find if CAR T cell therapy is good for other diseases like autoimmune diseases, solid malignancies, and other beta cell malignancies. In terms of the outcomes following CAR T cell therapy and what we know so far, not for ITU, just in general. So the CD19 targeted CAR T cells, they're likely to be curative for a subset of patients with beta cell lymphomas. Although these patients, they might need at the same time allogeneic hematopoietic stem cell transplants to enable long-term remissions in this type of patients. And for those who like the numbers, there are a couple, there are many studies that they have run. So if we all these studies, and if we follow up the patients at 24 months, specifically for the patients that they have a relapse of beta cell lymphoma and CLL, we have an overall remission rate of 44 to 91. This means the overall that it can be either complete or partial, okay? And then the complete remission rates, they can be from 28 to 68%. And there is a subgroup of patients which has been shown that even after 2 years from the infusion, they didn't require any more treatment for their cancer. This is a very good review in case someone wants to go further and search further information. So, well, we talked about the end of the CAR T cell therapy. So it doesn't come though with no side effects. There are some short-term complications and there are long-term complications. So the short-term complications are, as we mentioned earlier, the CRS, the ICANS, infections, hematotoxicity, HLH-like syndrome, tumor lysis syndrome. While the long-term complication, this is I really like, to be honest, this image, because it shows the timeline of what can happen. I know it's not very close for you, but I can explain it a little bit. After the first month, when we're away from all the short-term and acute toxicities from CAR T cell therapy, we can of course have on the top 3 lanes, the blue, you have the infections. We can be light bacterial infections, fungal infections, and PJP and all this type of infections. The most long-term complication is just because imagine that you're putting these killers in there, they will make the other cells, the beta cells or the T cells, to work less. So these patients are going to have hypogammaglobulinemia, and they are going to have an impaired beta and T cell function. These patients, they might have prolonged cytopenias, they might have late neurological and psychiatric effects, late immune-related adverse effects, and also they're at higher risk of developing further malignancies. How common these toxic effects are? Well, they are common. Most patients will experience the cytokine release syndrome. They will also develop in 20 to 30% neurotoxicity, which is a high grade, and especially with the products that are used here in the UK, there is a significant risk of delayed cytopenias. However, this specific cell toxicities, they're only responsible for the minority of the non-relapse deaths after CAR cell therapy, just 11.5%. The big killer, so the leading cause of the non-relapse deaths after this therapy, is infections, which is about 50%, to be honest. Infections, they can be subdivided into early, which means that they are less than 90 days, and then the ones that are more than 90 days. As we can see on the left side, in the early infections, we have mainly bacterial infections, bacteremias, and bacteria are isolated from the respiratory system, urinary system, or soft tissues. As the days go more and we go to more chronic, to chronicity, then we have all these fungal and opportunistic infections. So it is of no surprise that these patients will require a prophylaxis for pneumocystis, from toxoplasma, HSV, fungal, and HPV. So all this are usually, the hematologists are working it up, and most of the patients will be on some sort of prophylaxis. In terms of the risk factors, Reading this, you would think that, oh yeah, it's only them that have a risk factor for infection. But yeah, it's like every hematological patient, to be honest, they are at high risk of infection. So even more if they have a high grade cytokine release syndrome, if they're on steroids, if they had multiple runs of chemo or any other treatment before they undergo the CAR T therapy, if they had a recent infection, if they had transplant, if they have low IgG, or they have high disease burden on the bone marrow. I don't think these are all of a surprise, to be honest. And in terms of the management, I mean, it's a multidisciplinary approach. We have to make sure that we have a very low threshold on investigating these patients whenever they have a fever, they have like low neutrophils, and just try and get samples, get imaging sent, for example, biomarkers, fungals, if we consider that it's an atypical infection, just treat. And this is why, like the intensivists have to be in a very good communication with infectious diseases, hematology, and microbiology. The hematox score is a score that hematology really, I have seen that being used on the wards, and they use it to calculate the risk of infection, okay? So the lower the count of platelets, of neutrophils, hemoglobin, CRP, and ferritin, the higher the risk of infection, okay? The same low-risk score, they're using it for cytopenia. So what is the risk of this patient to be cytopenic after CAR therapy? And this gets us now to the next toxicity from CAR, which is the hematotoxicity. And it has evolved as one of the most long-term CAR T-cell related adverse events in the real-world clinical settings. So as we can see on the image on the left, neutropenia is something that it's really, really common. It can be protracted, meaning that it lasts more than 7 days, or prolonged. So this means that it can go up to 21 days. Then we have anemia, and then we have severe thrombocytopenia. On the right side, I found it like very, very interesting, this image, to be honest. So on the z-axis, we have the neutrophil count, and then on the x-axis, we have the days, months, like the time after patients have the CAR T therapy. So the number of neutrophils over time, so after the patients have the CAR T cell therapy, there are three phenotypes. There are patients that they are quick responders, so that they're neutrophils that have like quick recovery, and it is shown in green. This happens only in 25% of the cases, meaning that they will stop being neutropenic in about, I would just say, if you see that line is the 1,500, this is reached in about 14 days. Then we have the intermediate recovery phenotype, which is the most common at 52% of patients. And we can see that this is weeks, so 3 to 4 weeks after patients have their therapy. And last, we have the aplastic phenotype, which is 23% of cases, and it takes really weeks to months for the neutrophils to recover. In terms of the platelets, they are the ones that take a really, really long time, to be honest, to recover, weeks to months. With hemoglobin, the effects are a little bit like that. In terms of the assessment and the management, so we just have to assess, like review the medications. If there is any medication that causes hepatotoxicity, so we will just have to stop it. We have to address any deficiency of beta-12 or folate. We have to seek for infections and bone marrow disease or HLH type of inflammation, either to treat it or to do a differential really diagnosis, because this can really, really overlap. It's very, very difficult sometimes to know where we really are. And in terms of the management, it is supportive, meaning that we can give transfusions of blood products. We can treat the infections. We can consider giving growth factors such as GCSF to improve the neutrophils, but only after day 14. Because if you give it before that, it makes prognosis really, really worse because they make the toxicity even worse. You can give thrombopoietin receptor agonists in case like they have very low platelets, or you can just go with stem cell boosts and transplants of bone marrow. So CRS, the cytokine release syndrome, this is one of the most common acute toxicities and the reason that patients come to ICU. In terms of the pathophysiology, there is a release of pro-inflammatory cytokines from the CAR T cells, such as TNF and interferons. And then these cytokines, they recruit and activate other immune cells, such as monocytes, macrophages, dendritic cells, T cells. On their term, they just also secrete more inflammatory cytokines, and all this results in endothelial activation, with the stabilization of vascular integrity and capillary length, and coagulopathy. And then all this acts really as a feedback molecule. So it just feeds itself, really. In terms of the grading of the severity and the clinical features of CRS, or what to expect to see, so usually it happens 2 to 7 days after they get the transfusion of the CAR T cells, although there are some cases that they might it might happen later. So they can start with really small things such as myalgia or arthralgia, but then this can develop into more serious conditions, and patients become tachycardic, hypotensive, in shock, hypoxic, have respiratory failure, have arrhythmias. In terms of the severity, there is the grading from the American Society for Transplantation and Cellular Therapy. So we have 4 grades. The higher the grades, the worse the CRS is. So in all grades, we have a fever, which is above 38. And then there is hypotension that might require vasopressors or not. So if they don't require, there is some hypertension, but they don't require vasopressors, then we're talking about up to grade 2 seriousness. If they require vasopressors, we're talking about grade 3 and 4. Or they might be hypoxic, and if they require, for example, oxygen in any sort of device of more than 6 liters, this is the cutoff to say that we are on grade 3 now, while grade 4 is the worst, and they require mechanical ventilation or CPAP. In terms of the management, antipyretics, you just start, treat really symptoms, and then you escalate it in a stepwise approach. So antipyretics, you start antibiotics. Tocilizumab is really something that's used in order to decrease this inflammatory response. When patients start having higher grade CRS, and they have hypotension or oxygen requirements, they will require fluids, like vasopressors and steroids. If they're on the ward, steroid of choice is dexamethasone, but then as we go on the more serious CRS, they will go to ICU and they will get methylpred. The next neurotoxicity that we have with CAR therapy is the ICANS. Again, like the pathophysiology, it is poorly understood, but there is activation of the endothelium. There is blood-brain barrier disruptions, and then we have the trafficking of the CAR T cells into the CNS. We have also passive diffusion of a lot of cytokines and inflammatory processes. So this happens usually 4 to 5 days after the CAR T cell therapy, but there are cases that it can happen up to 4 weeks. And usually it occurs at the same time with the CRS, but it can happen also, like after the resolution of the CRS. In terms of the clinical features, patients might have headache, might be confused, have impairment of attention, myoclonus, and then this can develop to the more serious cases of encephalopathy, low GCS, coma, seizures, and even hemiparesis or paraparesis. So as with the CRS, we grade the severity of icons, again, in grades from 1 to 4. So in the grading, we use any, whoever has like a depressed level of consciousness, seizure activity, any motor, findings, or any signs of elevated ICP, and a high I score. I'm going to talk about it in a bit. All this make the icons of very serious, of high severity. The I scoring is something that they use again on the wards. So they check the patients, how oriented they are, if they can, how are they, if they can follow commands, how, if they can write down things, if they have like attention or inattention, then, if they score high, then this means that there is some sort of encephalopathy happening. In terms of the management, seizure prophylaxis, we can just give levetiracetam. We give tocilizumab, but only if there is CRS at the same time. We monitor, with imaging, with endoscopy, just for any, signs of raised ICP. We give steroids, and then again, the higher it is, they might need, to come to ICU for further management, airway protection, management of seizure, or to lower the ICP. I know that this presentation says here neurosurgery, but I'm not a hematologist, but I consider that that's a bit probably too far. But yeah, that's the whole thing. Last, from the acute toxicities, we have the immune effector cell-associated HLH-like syndrome. So this is a secondary HLH syndrome. So all the inflammatory cytokines that they happen after CAR T cells are infused. Then we have, the activation of the macrophages that they do their own thing. So it presents with fever, high ferritin, dearranged LFTs, low fibrinogen, cytopenias, and signs of hemophagocytosis in different tissue biopsies. So what can happen is that it can happen together with the CRS, and that is very difficult to do a differential diagnosis right there because they have a lot of common features. But if, for example, you have the initially you have the cytokine release syndrome, and then the patient becomes better, and then they have like these features, this is probably in favor of saying that yes, we have HLH here, secondary HLH. Factors, you're still going to manage these patients as you would, like the supportive care, treat coagulopathy, give fluids, oxygen, or whatever they would need. But it just has a worse, really, prognosis, the HLH. So what about now the implications for us as intensivists? So critical care and ICU specialists, they play an important role in the management of patients that they receive these therapies. There are observational studies that they report worldwide that 27 to 35% of patients that they get CAR T therapy, they will end up in ICU. And with the expansion of the CAR T cell technology with newer indications, it is predicted that we are going to have an increase in the demand for ICU beds. I'm sorry, it doesn't look very well, but anyway, there is, yeah. So I found that there is this multi-center retrospective observational study in the UK, 90 years in the UK, from 9 centers that they give CAR therapy, and they have specialized, like ITUs, they're very special really for this type of patients, and it's called the CAR group. So in these 4 years, from 2019 to 2021, they had 363 patients that they had apheresis in order to have CAR T therapy. Three of them, like 1%, did not really progress because the patients, they really became deconditioned in this time point until they have the infusion of the CAR T cells, and 29% of them were admitted to ICU, so 1/3, okay? The median age, it was about 58 years old, and 42% of them were female. The underlying malignancies were mainly diffuse large beta cell lymphoma, 74% of the cases, and mediastinal lymphoma in 17% of the cases. In terms of the specific toxicities, so most of the patients that came with CRS had a grade 2 CRS, so it's not a very high grade. The patients that came with ICANS, again, 10% was a grade 2, so that we see that mainly it's the lower grades of CRS and ICANS that they end up to us. There is though a 24% of patients that they came with both a CRS and an ICANS. A very small amount came with the HLH. In terms of organ support, therapies and diagnostics, 21% of the patients that came to ITU required intubation and ventilation, 4% required NIV, 40% required vasopressors, 6% renal replacement therapy, while 27% just required monitoring. They had their treatments, they had diagnostic procedures, so imaging, CT, MRIs, EEGs, LPs, echoes, bronchoscopies, like microbiology samples. We can see that most of them did, and this is a big burden actually, if you think about it. In terms of the outcomes, the length of stay, the median was 4 days. The mortality was 12%. The hospital mortality was 19%. The 6-month mortality was 54%, which is quite big. After 4 years, alive and in remission was the 40%, but not from the beginning, from the, like we really go to really small, to be honest, like numbers. So 41 patients from the 360 that they had initially. And then alive, but in relapse are 23. So coming now to the end of the presentation. So in terms of the CAR T and the ITU, so in the UK, the use of ICU resources for patients that have CAR T cell therapy is significant, but it is predominantly for monitoring purposes or single organ support. There is a significant proportion of these patients that require invasive and non-invasive diagnostic tests. The ICU length of stay is short, but the ICU hospital and 6-month mortality, it's quite significant. In general, we can just say that these therapies are developing rapidly with an increasingly wide range of indications for hematological malignancies, but they have the potential as well to be used for solid cancer and autoimmune diseases in the future. They have demonstrated satisfying response rate and improved survival rates in patients with refractory or relapsed high-grade beta cell lymphoma. They have important specific toxicities, mainly the CRS, the ICANS, hematotoxicities, and the HLH type, while the main non-specific complications are infections and sepsis. The most severe cases may require admission to ITU for early management, and an MDT approach, so hematologists, intensivists, infectious diseases, and micros, they all have to be involved in order to get the best patient outcomes. That's it. Any questions? Yeah.
So which healthy
So if you think about it, for let's say for blood marrow, this is what you think: antibiotics. These are one of the main things that you would consider. Okay. And they are on antibiotics, so that makes it also a little bit difficult on what to switch. This is the main thing that I would just say in ITU at least. Yeah.
And the most common toxicities seem to be CRS and ICANS.
Yeah.
Is there any role in prophylactic one can do about these patients?
So I am not aware about all the literature, I'm not going to lie, but yes, it is the most common, but it doesn't mean that it will happen. So unless you start having, like this symptoms, and also if you remember, you start using tocilizumab when they're grade 2 and further. You might have like some very subtle, which is like grade 1 CRS or items, but then you wouldn't give tocilizumab. And again, like on its own thing, it will also have like important side effects. Anything else? Okay. All right, thank you. If you could just give me some feedback and just get your certificate, that would be great.
There's a lot of chat about having these patients, but
We are
going on for 2-3 years.
So, you know what, I am afraid that we're going to have a serious issue, and especially when I'm thinking, like side rooms of these patients. Like, and it's not only that they're good. I am pretty sure. So yes, the median is 4 days, but if you see like the ranges, they can be 1 to 2 to 30 days. So this is a little bit. I'm afraid we're going to have a like issues with resources, but this is also like something that, again, on the other hand, we can use it in order to maybe get a new building. We have like more side rooms, Yeah.
Or just have the
I hope so.
RT,
Yeah.
which shouldn't be a massive burn. I can't imagine they're going to ramp up a huge number of patients, because looking at that was a period of what, 3 years?
Yeah,
They
for
had-
4 years. So they have 360 patients almost. Yeah.
Ultimately, that's split between 9 centres.
Yeah.
So they're getting 40 patients, and they were seeing 10 of those come to intensive
Yeah.
care, and actually the grading of the how
It was the low. Yeah.
They almost seem to be admitting them prophylactically.
Yeah. So I checked a little bit about the admission criteria, to be honest, and they said that there's no definite. I mean, of course, anyone decide however they want. But when they started to be, like a grade 2 to 3, they would come to ITU. That's it. And then it could have been, for example, that they have even grade 1, but there was some sort of other concern, and they would be admitted. So that's it. It is just. Yes, and you know what? Initially, they're saying that they're going to have, I think, here in Leicester, they were just saying about 3, 4 a year, but it's not going to stay there, because they're just starting, and also the numbers that we saw these are when they also all these centers, like started really to get into the cardiac. So this is a really small. I think that numbers are going to be much higher than that.
We'd imagine the first year you probably get 1 or 2, and maybe you hope that that's it.
Yeah.
But yeah, you can imagine having 1 month.
Yeah. The only, the only thing that scares me also a little bit is like by just checking a little bit. So, of course, the outcomes from CAR T therapy after 65 years old is worse, but there is like this. They insist that you should always consider, like the performance status rather than the age, which is again like I'm afraid that we're going to see, like there are studies that they are giving it to patients that they're like 75-year-olds and things. So this is going to be a bit tricky, I feel.
Robust assessment, I'm sure.
Yeah. Yeah. So these centers, from what I could tell, the intensivists, they were involved from the beginning. So like, yeah. So if we are like, we will have to be involved to, like the discussion with hematology for whoever is going to get it. So before they get it, to make sure that we set the correct, like limits of escalation, and this has to be like discussed beforehand. And also like they have weekly, like meetings and things like this. And when the patients come for the CAR T therapy, every day they're assessed by intensivists. on the word. Yeah.
It'd be interesting, because I don't think it would just be an assessment rather than sort of setting limits. You can imagine that it will just be you're going to have everything, or you're not going to have it at all.
This is what will happen now. I think that in the beginning we're just going to leave everything open, everything, but there will be for everything. Yeah,
Ridiculously expensive.
it is. So I checked one patient. So the CAR T therapy for one patient, it's £300,000.
Wow.
Yeah, I checked. I was like, let's just see where we are, because that's a hazard, like, as well. If you think it's a long-term toxicity from CAR therapy.
Going back is like, how many of these needed renal replacement?
I think it was from the UK data, it was 9 from the 100, so 9% of the patients. But you know what? This is only this is like, how can I, they might have like tumor lysis syndrome, for example. This is only for the ones that they came for the specific toxicities from CAR. I love it how they phrase it in papers and in research studies and things. This was specifically for the patients, the numbers. They had like the icons, the HLAs, and the neurotoxicity. Okay.
People say,
Yeah, I find it very exciting, to be honest. Like, as therapies, I think that they are very, very promising, and I think that these are like, it's really life therapy, and I think that's it's really personalized, if it makes sense. And I don't know, like I'm fascinated by it personally.
you can imagine looking back in 20 years' time, they develop something solid tumors,
They were.
and there'll be chemotherapy between, hopefully, all the parts.
Yeah. The problem with the solid tumors is that there is a lot of heterogeneity in the cancer cells of the solid tumor. So it's difficult, like they find difficulties in general with CAR therapy. And even CAR therapy, like itself, it looks like there are issues around it. So, for example, it can be that the cancer cell would just stop making the antigen, or like the other thing is it it is on target but off site. So they just like kill so many of the natural like cells of the host cells that they just make it not worth it, to be honest. And yeah, there is a lot of research still, I think, to be needed to be done in the lab. There is. That's why I like it.
Super.
Yeah. Thank you so much. Thank you for your attention. Oh dear, I can't hear anything. Oh,
So,
I have like blocked ears. I have sinusitis, and it's getting awful. Like, it's fine when you wake up, but after a couple of hours, it just starts. I feel like an old horse. I said that, like they're gonna put down or something.
I think you've got a few minutes.